That chart is a digital tool, and it helps in the assessment of healthcare facilities vulnerability to health or climate hazards for planning and early warning. It is built on the WHO framework, enabling risk profiling, service disruption, forecasting, as well as resilience. It has a dashboard that integrates or is integrated into the DHIS tool and helps to aggregate the field data and present it through an interactive and real-time visual dashboard like you may have noticed from the display.
Flood was not even mentioned in the northern part of Nigeria, but at that time we actually had flood in one of the northern states, and it washed out almost an entire community. So that was a red flag that the climate change is real, and we needed to do something about it. And what complicates the problem is the fact that when such hazards happen, they come with complex health-related problems, and these health facilities are not resistant or resilient to those hazards. So where you would now be taking or saving lives is also part of the crisis, and that's why we now narrowed down to the health facilities. What can we do to improve their resilience to such hazards? And that's when CCV HVAC, which was initially the name of the solution, came up. We identified the niche, and then now it's find a solution. And we didn't jump directly to innovating or creating a new system. What we did was to look into the ecosystem and see what solution is available. And what we found was the WHO assessment tool. But then the gap was that it was not accessible. It was too complicated because it was a text-based system. So we arrived at that innovation to digitalize that tool into a more accessible and simplified solution. And when it came to the design, we were very deliberate to focus on the key design principles that will make the tool easy to use by the targeted clients. And first of it is the fidelity. We ensure that even though we are digitalizing the system, but we are keeping all the terminologies, the logics to the questions, and the recommendations that came with the tool intact as it was in the WHO guidelines. The interface and experience, this is something I'm sure most of you that are working with the public health space is important. For your tool to be able to be used by the target clients, you have to pay attention to the user interface. So we try to streamline all those long checklists into a guided, bite-sized modules with clear navigations, which you must have seen on the demo. With auto saves and stop and resume, because we know how busy the health facilities are. So you have to be very mindful of bringing a solution that they would be able to complete at their own pace and be able to pause and resume when they have the chance. And some of those questions may require them doing some investigations within the facilities to dig up some of those information. Like Tony mentioned, some of this data was not available before this tool come into existence. So we also are aware of localization and context alignment. So we prioritized the most relevant hazard areas. Those three that were projected were not all of them, but because those were the priority, and we also aligned those three priorities to the relevant health facilities depending on their locations. With the grading scale, you must have seen 1 to 5, but originally on the tool it wasn't 1 to 5, it was a text-based grading system, which we understood that would not be easily translatable by the health facility managers and health workers. So we had to now transform that to a numeric 1 to 5 scale. We're also working on a multilingual feature, which we think is very important, especially on this continent where we have different languages, so that it also is in the pipeline. One other key design feature that we were very mindful about is the fact that this tool is meant to be transitioned to the health facilities, which are mostly owned by the government. So sustainability and compatibility were very important. So we made sure that we minimize the hardware requirement of this tool so that health workers will be able to use any kind of device that they have. And also platform independent, so it doesn't matter which iOS or which kind of device we're using, whether it's a tablet or a mobile phone or a laptop. And also, as with all our solutions, we have a user guide, which is also deployed on our e-learning platform so that health workers, as they come in and go out of their roles, are able to train and retrain themselves on the use of the tool. Now, after the pilot, the success that was recorded, the demand was very clear. Then there were questions that we needed to answer, and one of those questions is how do we scale up? And with scaling up comes with a number of parameters. First is interoperability, coverage, which I think Toju has touched on, Temi has touched on, alignment with government policies and frameworks, and also integrating with other solutions. And that's where DHIS2 now came into play. We had no better option than to transition from the custom-built CCV HVAT to the now currently DHIS2, which makes everything seamless for us. Once it's a DHIS2 app, then it is easily interoperable with the rest of the global good tools out there. The coverage, that was easy. Almost everybody within the ecosystem uses DHIS2. It easily aligns with most of the government policies and frameworks, some of which are actually even built around it. And also, like you have seen, was able to allow us to integrate with any kind of analytics dashboard, which in our case was based on Power BI. So in summary, what was I trying to answer is that when we come to the design, co-creation and co-design was key. Without that, we wouldn't have even come to this room, because we could have designed a tool that wouldn't have been used by the target users. We were focused on the problem. It was never about the technology and how complex it should be. It's about how do we solve a problem. And that's exactly what we did, like mentioned by Temi. And most importantly is the simplicity. You don't want to add any complexity to the existing work that these people do most of the time at an emergency situation. So we try to keep everything simple and seamless. Thank you. And sorry, I know that I've gone beyond the minutes. Thank you.
I work on climate and health a lot, especially climate and health analytics, focusing on South Asia and mainly in India. And we do have, like at the World Bank, we did develop a climate health vulnerability assessment, and one of the components of the climate vulnerability assessment was what you just mentioned, like the climate resilient health facility tool, and we did use the WHO framework for that, but we wish we had like a tool like this, because we were relying upon Excel sheets and spreadsheets. So, and we had to contextualize, because as you know, that WHO tool is quite intense, a lot of questions, quite exhaustive, and we had to sort of contextualize, because you mentioned about flood and drought and heat, and these are present in India as well, but there are other climate and environment related challenges that we face, like air pollution, which is a huge problem in our country. So we had to use some of those, we had to look at health facility resilience in that angle as well. I had a couple, I have a lot of questions, but I'm not going to ask those. Maybe we can have like a discussion offline or virtually, like later on. But I really wanted to understand, like you talked about, self-assessment, because these health facility assessment, using this chat would be done by health workers themselves. So I want to understand what's like the training module or the form of training that you give to these health workers so that they'll be able to use this tool to assess their health facilities. And also, like you also mentioned that this is open source and this can be sort of scaled up in other countries in Africa, or maybe like in other countries outside of the continent as well. So is there a possibility to sort of contextualize this, like and how do you do that, like if we were to add more questions which are maybe contextual or to the climate related hazards of that particular country, how do you do that, and what's like the mechanism, and what's like the technology transfer that you have vis-a-vis this tool? So those were some of the questions, maybe if you can answer those. But really glad to see this happening, because and how you are leveraging digital technology to address climate related health hazards. So kudos to that.
All right, so I will take the first question around the self-administration and training. So for the first phase of the assessment, the pilot phase, which we're calling it, we administered the tools. So we had enumerators trained to administer the tool to the healthcare, to the health facilities. The goal ultimately is for the facilities to be able to self-assess using the tool. But for this first phase of the assessment, we felt it was important to administer, train, standardize understanding across a group of enumerators. And this was also bearing in mind, I would say, the time frame we had to be able to implement this, right? So in terms of training, we of course developed a standard training curriculum based on the framework itself, and also contextualizing it, knowing what is applicable within our context. So developed training curriculums, had intensive training sessions with the enumerators, had pilot assessments, say maybe in each state, maybe 1 or 2 facilities during the training, got feedback from the facilities as to maybe the understanding, or even the enumerators, the understanding of the questions, how the responses were, and all of that. And we use that to sort of tailor or adapt the tool as may be, to ensure that there's that uniform and standardized understanding across both for the enumerators and the healthcare workers. But like we said, the goal eventually is for healthcare facility staff to be able to self-administer, and the trainings will most likely take the same format: standard training curriculum, intensive hands-on training, pilots to make sure that they understand, and then So David, the next question.
Okay. Yeah, maybe what we did, I'm not sure whether I missed that or it's part of, it's that for this application you have the mobile version and you have the web version. So the mobile version is what is deployed at the health facility level, which is just for assessment, and that's why it's very easy to train, just like what Temitope have explained. So it's just for them to understand simple use of phone. It's just a plug and play and selection, so it's quite easy. So for the adaptation, yes, and I think that's one of the things I mentioned, that the tool is adaptable to any context. Maybe we said Africa, but beyond Africa, easy to adapt. And we did that by being intentional about a few things. Number one is that the tool is developed with what we call a modular structure, which means it allows you to add any other climate event as a module. And maybe the other ones you want to disable if it's not applicable in your context. So it allows for that. Then the other part of it is that it also allows you to edit any relevant questions or assessment benchmark that you want to. But what we want to necessarily maintain, which might be for purpose of global standard, is the analytic part of it, because we want to make sure that whether you get to assess it in Asia, in Africa, we are seeing the same analysis.
If you can add on a component that looks at young people doing maybe WASH assessments, some level of assessment in the community, that gives them a voice in what is happening. Because when we look at youth climate action and all of it around it, a lot of climate health issues that are happening right now are not happening for this generation. They are impacting on the next generation. So I would just, that's looking at it. Then also, I want to take us to the recently the Lancet report that was recently launched. It looks at, okay, it's not about just collecting the data. It's about how the data is used. With chat position us where we're able to collect the data right now. But do you see chat also, what possibilities of chat also helping us to actualize and achieve the aim of what we are trying to solve here?
Actually, to ensure that we move from just this developing the tools to its own utilization. You can see there was a time I even told some of the researchers, you make sure you link with the government, so that as soon as you have your own findings, it's already put into use by developing appropriate policy or legislation. Now, the tool, because it's in line with the WHO framework, climate actions, including the nationally determined contributions, they are considered as a national plans. Okay, so and these national plans, they are integrated into the national country plans. Okay, where we incorporated into the medium-term development plans, and these medium-term development plans is used to drive annual budgets, and then of course, as a national planning, you plan for the activities, and not only in the budget, but also even micro plannings, so that you'll be able to utilize the data that is used in allocation of resources to ensure that there's efficiency, allocative efficiency. And then, the tool also talk about healthcare workers, okay? WASH. It has been found that an investment, ₦1 investment in WASH brings about 4 naira returns. So government would like to do that because there's evidence and it will be part of the planning. So there's a lot of efforts in trying to integrate findings like this, tools like this into planning. And another aspect also, if you look at the healthcare workers, there's also needs also for their capacity building, for their own distribution, and then training climate smart health workforce. This tool will help you to understand what's happening with healthcare workers. Do they need capacity? Do they need distribution? And post-flooding, we have cholera outbreaks. It's not increasing burden or prevalence of vector-borne diseases such as malaria. So this also helps in your planning and in the early warning and so on. So government actually will be willing to, when they have evidence like this, because you need the evidence so that you deploy your resources, you deploy your interventions based on the needs. Because if you look at our map, Nigeria's map for BNA, you see that not everywhere is red, not everywhere is green. And as I mentioned, it's community specific, vulnerability is community specific, and this will really help. Thank you.
Thank you very much.
I think the only thing to add also is that part of the tool is not only to collect the data, but there's also recommendation. So based on the assessment, the tool is able now to make recommendations where the investments, where the gaps are. Because after all, what it's trying to do is to assess a health facility and tell its readiness if this particular hazard would hit that location.
Thank you. Okay, thank you very much, Madam Temita. Are you adding or okay?
No,
I think Tahir wants to make some contribution. And then
Good evening, everyone. My name is Tahir Boy, and I am with the eHA team. But I just wanted to talk, from my own personal perspective of what I've seen from this tool. I think for me, this is just the beginning for what this tool could potentially achieve. Because once you are able to empower health facilities to sort of use this tool to self-assess, to understand what their risks are, and then to also help them to develop mitigation plans, I think that's just the beginning. Once you have that data, for me, I could potentially even see a situation where you have machine learning models or AI models trained on that data, right? And then you are using all of that information, in a predictive way to also inform investment decisions that government is making as to where should we focus, our investments in terms of the risk profiling. So that's why I think that partnerships question is super, super important, right? How do we take this tool? There are so many different use cases that we can potentially see for the tool. How can we work with you guys to, take this through to the next level?
Quickly, I think there's a question around the youth that we didn't quite address yet. So the chat as it stands right now is for healthcare, health facilities, vulnerability assessment. And where we do see the youth coming in is, of course, the youth are part of the communities where this facilities sit, right? And as everybody has said, the first step is identifying what the vulnerabilities are, where the gaps are, planning towards adaptation planning. So where we do see potential for youth in this is in terms of implementing some of the adaptation plans, right? We cannot do that even at the subnational level. You still need that community engagement, community involvement. So that's where I would say that I see the youth coming in being able to support the community-based adaptation planning, as well as the community-based adaptation sort of implementation, and at the facility level, because at the end of the day, the facilities are there to serve their health needs. So,
thank you very much for the valid point. And without even being intentional, interestingly, more than 90% of the enumerators fit perfectly within the categories of youth. More than 90%. I mean, I can talk about that for facts. And this leaves critical mass of trained people in each of the LGs that can be deployed quickly. They sit right in my WhatsApp group now, and we quickly deploy them if we have to. I remember in one of the states where we deployed, they were like, now that you have trained the people that we know, you selected these people and all of that, we want to do more facilities, because these are people that actually went and only supervised. So that's how you can see where the youth come in. And just to build on the point that Temitayo has said about implementation, they are leading the process in terms of enumeration already. Thank you very much. All right, so we are going to close now, and I'm told that the Director of Partnerships and Program will be giving us the close. Thank you very much. Please make welcome Madam Otta Ayudo.
Thank you so much. Thank you, David, Jamil, Temitayo. Thank you, sir. Thank you to everyone for actually joining us for this session, staying till the end. Unfortunately, we're out of time. We see that the conversation was getting more interesting, and we feel like we would have had more questions and comments. But the team is going to be around after the session so that we can take on the conversation, and also for the climate adaptation team to shed a bit more light around the work that we're doing with the chat tool and the adoption. I think we didn't talk about it enough in terms of the interest, even from some institutions around the globe, and how to take up the adoption. So just to say thank you so much on behalf of eHealth Africa. We really do appreciate you, and we're hoping that we can take on the conversation from here and have more progressive discussions. Thank you and goodbye.
Thank you very much, Madam Otta. Please a bigger round of applause for my director.